afternoon, everyone. Welcome, and thank you for joining us for the second in our webinar series on bridging Ryan White providers and FQHCs. My name is Andrew Weddle, and I am the Executive Director of the HIV Medicine Association. HIVMA is sponsoring this series as part of its project to develop tools to help HIV providers adapt to healthcare reform. And this project is supported with generous grants from Janssen Pharmaceuticals and the MacAid Fund, and I just really want to thank them for their support of the project. Now, today's webinar is the second in the three-part series, and with this series, we're really hoping to provide some information and tools for Ryan White providers so they can evaluate their options for partnering with an FQHC or becoming an FQHC. And with this session in particular, we'll dive deeper into the pathways and options for becoming an FQHC. The first webinar, if you missed it, provided an overview of the 19+ requirements for becoming an FQHC. And if you missed it, it is now archived on hivclinician.org and will also be available on hivhealthreform.org. Before I introduce today's speakers, a couple of housekeeping notes. We are recording today's webinar, and it will also be available online. So please feel free to share it with participants, or if you want to go back and listen to some of the information again. Also, all of the participant lines have been muted, but we really want to hear from you. So please submit your questions using the question box during the webinar or after we conclude the webinar, and we'll get to as many questions as possible during the Q&A period. Any questions that we are not able to get to today, we will address at the beginning of our session, of our next webinar session that will take place on June 10th, also at 1 p.m. Eastern. So now I'm really pleased to turn it over to our experts today from Feldsman+Tucker+Leifer+Fidell, which is a firm specializing in federal grants, health, and family law. First, we'll hear from Emily Pinkham, who is an associate at the firm, and she's going to follow up on a couple of the questions that came up during the end of the last webinar. And then she'll be followed by our main presenter, Catherine Watson, who is also an associate at the firm. So take it away, Emily.
Great. Thanks, Andrea. Welcome, everyone, and thank you for joining us again today. And first, as lawyers, we, of course, have to offer our standard disclaimer. So this presentation is intended for general information and educational purposes only. It is not legal advice. And to the extent that you do need further legal advice, we recommend that you consult qualified counsel for specific guidance on your questions. So before we move on to today's topic, there are a couple questions from the first webinar that we wanted to address briefly. Most of the questions that you submitted were either answered during the webinar itself, or we've posted them online in the Q&A document along with the archived presentation. So the first question is, are there specific numbers of clients required, especially above and beyond current clientele? And the answer is both yes and no. So it's no in the sense that an FQHC does not need to meet a specific number or threshold of clients, but must generally offer primary care services to all members of the underserved community in the health center service area. However, as part of the application, both grantees and lookalikes must represent the total patient population that they intend to serve, and this includes any anticipated annual growth. So if the actual patient population that you represent in your application is significantly lower than the one that you described, there could be some serious consequences. For example, there may be a reduction in your grant award to compensate for the lower population. The second question is, under what circumstances can an FQHC be a subsidiary of another organization? As we mentioned in the written answers, HRSA is particularly skeptical of arrangements where an FQHC is a subsidiary of another corporation, because corporate autonomy is really a key facet of health centers. And in a parent subsidiary model, parent companies generally reserve certain powers and authorities that could supersede those of the FQHC's board of directors. Now, I should note that subsidiaries are not the same as subrecipients, though the concepts are very similar. And Katie's going to address the subrecipient model later on in this webinar, and we'll address subsidiaries a little bit in the context of other collaborative models in our third webinar on June 10th. So with that, I will remind you to please submit your questions as we go along, and I will turn it over to Katie for today's topic.
Thank you so much. today, I am happy to have the opportunity to present to you the pathways to becoming a federally qualified health center, or FQHC, as it's been referred to, and will be. And I also want to thank HIV Medicine Association and the funders for this project. I also appreciate the fact that all of you have tuned in today and you've taken time out of your busy schedule to join us. And I look forward to your questions. As Andrea said, please enter questions as we go in the chat feature, and we'll be sure to address them at the end. So as background, I'm going to stick with a little bit of background of just saying, my name is Catherine Watson. I'm an attorney with Feldsman+Tucker+Leifer+Fidell. And Feldsman+Tucker+Leifer+Fidell is the general counsel to the National Association of Community Health Centers, and then has this niche in federal grants and healthcare. So we represent federal grantee health organizations in nearly every state in the country. So with that perspective, I have the fortune of working with a variety of Ryan White grantees on pursuing the pathways to becoming an FQHC. And today's agenda, we're going to start with a refresher around FQHCs 101, because as much as this is the second of 3 webinars, they're also designed to stand alone. And I expect that not everybody attended the webinar 2 weeks ago on the 101. If you did, there might be a little redundancy, but hopefully that's helpful. And I just want to push that out there first, and then we'll get to the heart of it with the pathways to achieving FQHC status, finishing with ideas for taking that first step down whatever path you choose. So the next slide. And the next slide. So what is, one back, slide 7, please. So again, as a standalone, we're going to do a little bit of a review, and we're going to be touching upon the key points. As far as what is an FQHC, there's 3 different pathways, 3 different types, if you will, of an FQHC. First, you have the grantee. The grantee is probably the most commonly understood one, where you have a community clinic that received a federal grant under Section 330 of the Public Health Service Act, and we put the legal citation in there for ease of reference. These grantees exercise the full benefits of being an FQHC, which we'll discuss more later, and they get the grant, and they are capable of being a prime grantee to a subrecipient, which is the second model. The subrecipient is an entity that's otherwise eligible to be a grantee but did not receive a grant under 330, rather has contracted with a prime grantee to receive a portion of the grant in order to perform a part of the prime grantee's scope of project. This will obviously be fleshed out later. The third pathway is an FQHC lookalike. The lookalike, I believe you all are probably familiar with this term. It's one where it's not a competitive process to become a lookalike. However, you have to be fully compliant for the last 6 months when you apply. So there's kind of a high bar. You have to be fully compliant with all the 330 stuff, but then you don't get the grant. So why do people do that? We'll talk about that a little bit more. One quick footnote there is that, well, it says here that the FQHCs are nonprofit tax-exempt organizations. There is a small slice of FQHCs that are public health centers, about 5% or so, and that would be where a public entity, such as a county or a public university, would be the awardee of the 330 grant, and then there would be a separately established board governing that health center. So that's a bit of a niche within the niche. So we'll go ahead and move on to the next slide. So what is an FQHC? Here I have 4 bullet points. This is far from a comprehensive list, of course. If any of you did attend the 101, you know that there's the 19 program requirements. You might know that anyway. So what am I doing with just 4? Well, when you think about an FQHC, there's 4 core elements that are just the baseline, and that is that they need to serve a medically underserved area or a medically underserved population, to be discussed further. It has to have a community-based board of directors where 51% or more of the board members are patients, and has to provide comprehensive primary and preventive care services, and then serves all patients regardless of ability to pay, which Emily had touched upon. So next we are taking a poll. So with the next slide, we'd ask that you'll see that there's 4 choices. What is the greatest attraction for your organization to becoming an FQHC? The options are FTCA coverage. FTCA stands for Federal Tort Claims Act. That's around medical malpractice coverage if you become a grantee. Prospective payment system, otherwise known as the fair reimbursement under Medicaid, Medicare. Integrated care model, or D, other. If you select, oh, cool uniforms. That, I think, got dropped out from the, that was an earlier version. You may still select it. The other is something that you would need to, if you choose that, I would ask that you please type your answer into the chat box that is presumably on the right side of your screen. So we'll give you a minute to do that. Let me see. This might go back to Andrea for a minute.
I'm not seeing any other in the chat box right now.
Oh, I think mine is actually.
Okay, no, here we go. It's coming under questions. So.
Okay. Sorry. Thanks, everyone.
And so the one that I see is the prospective payment.
Okay. That is, yep, that is, I think, the same as B in terms of the higher reimbursement, if you will, under Medicaid. So on my screen, I can't see any poll results or slides right now. So I'm going to see if anyone can type into chat or questions. If they can see the slides, then we'll keep moving forward. Okay, great. We're back on the slides. So obviously there's no right answer. This just shows that there's different motivations for pursuing FQHC status. And these are the common ones for Ryan White grantees in my experience. I don't have the 340B drug discount program in here because as a Ryan White grantee, that organization would already be eligible. So oftentimes that's not going to make the difference in terms of doing the task required to become an FQHC. So, but this just highlights again the motivations and some of the benefits that come along with becoming an FQHC. So next slide, please. Hello? I should do a quick check.
Yes, hi. Did you see the grantee model slide?
This will just be the pathway slide.
Okay.
Just want to make sure that we're all in lockstep right now. So now we get to get to the heart of the presentation. FQHC status can be obtained in one of three ways, and regardless of the approach to obtain FQHC status, all FQHCs must comply with the legal requirements under Section 330 and its implementing regulations and agency policy from the Health Resources and Services Administration. Again, as Ryan White grantees, you're probably quite familiar with HRSA. Within HRSA, the Bureau of Primary Health Care is the one that eats, sleeps, and breathes health centers. And the implementing regulations for Section 330 comes under 42 CFR, Code of Federal Regulations 51C. And it's full of different requirements for governance, for board authorities, and et cetera, et cetera. So the grantee model is what we're going to talk about first. An entity may become an FQHC by virtue of being awarded a new access point grant. The grant application is highly competitive. You'll see here that the maximum annual grant request is $650,000. At least I actually have to put a footnote to that because there was about 2 years, a year and a half ago, there was a surprise round of new access point grants awarded. I believe when the federal government decided that they found a little extra cash. and awarded to former applicants who had not gotten it in the first round. All of a sudden, there was a surprise second round, and a few people actually exceeded that amount. But generally speaking, that is the maximum NAP award to receive. And you must propose to establish a new service delivery site, either your new organization altogether, and the new delivery site could be an existing clinic, like a Ryan White clinic, or for those who are FQHCs, perhaps they want FQHC status for satellite sites. So that it explains that element to it. You have to propose to provide the required scope of services directly or by formal arrangement. HRSA has a Form 5A that goes with the FQHC application that is very illustrative. If you go and Google HRSA Form 5A, it'll come right up, and it shows the list of required primary and preventive services that an FQHC must provide directly or by referral. We're going to touch on this again today, but the referral part will also be discussed further on June 10th. And you must propose to serve a federally designated medically underserved area, medically underserved population, unless requesting only special population funding, the migrant, homeless, and public housing. So 2 points with this really quickly, which is with special population is a term of art for HRSA in this context. And for decades, it's only been identified as migrant, homeless, or public housing. Those are the quote-unquote special populations. And this can be a source of frustration for a lot of providers who understand the history of other populations that are underserved, medically underserved, and could benefit from such a designation, but that's very unlikely to happen. So when you think about special population, it's not meant to be place judgment as deserving or not deserving. It's just the history of the health center program comes out of migrant and homeless clinics. And so the expansion of special populations is probably not on the horizon, but it is understandable why that can be confusing. Also, if you do decide to go for medically underserved population, special population funding, it's very important to know and be confident that there's a need, B, you can really reach that population, and C, you can do it in a long-term fashion. For instance, we've seen an organization that applied for a public housing grant, and they got it. And they had this loose arrangement with the Public Housing Authority, but that actually ended up falling through about within the first year, and they had to give the money back. So it's just, you can be more competitive if you say you're going to reach a special population, but if you can't do it, then there's obviously risks involved. So must be operational within 120 days of grant award. So that's relatively generous, I guess. Next slide. Now the grant application process, I imagine, as Ryan White providers, you all are quite savvy when it comes to grant application processes. Here you'll see the HRSA grants, grants.gov. Again, this may be extremely familiar to you all, but if not, they're very important resources. So next slide. And it's multi-step, so you have to register, and then sometimes there is a period of time between when you register and when you can actually submit an application. So just making sure that you are mapping it out. HRSA does a nice job of walking potential applicants through the process. So I recommend looking into the future and mapping it out and timing it, and then of course pulling together your team to start chipping away at a great application. And quickly also I can tell you that when HRSA will go through the applications and take out those that are not complete or are not properly responsive, and then they will convene an objective review committee, an ORC, to assess and rate the technical merits of the complete applications, and then the ORC will make recommendations. Eventually, if you receive a grant, you will get a notice of award. Most recently, just earlier this month, HRSA awarded, I believe it was $10 million, and Emily, you can jump in if you want, but yep, more than $10 million to 164 health centers on May 5th. which is estimated to serve over 600,000 patients. So that was the most recent round of NAPS. Not an insignificant sum. So we can go ahead and move to the next slide. So that was a grantee model, which I think is, well, the most common model, and it's also the most commonly thought of model. The subrecipient model is the opposite. It's the most rare and the least thought of model, but it exists. And there's pros and cons, like everything. But essentially, you've got that prime grantee, which would be one of the entities that I just spoke of, where they award a portion of the 330 grant to another entity, and that other entity, the subrecipient, provides certain services on behalf of the prime grantee. There is, of course, a contract between them, and that's where the qualified legal counsel comes in, this subrecipient agreement. And HRSA will look at a subrecipient agreement. What the next bullet says, the final bullet says, is that the prime grantee maintains a direct reporting relationship with HRSA, and the prime grantee has oversight authorities over the subrecipient, which is operated as a separate and autonomous corporate entity. So the relationship, there isn't a direct relationship between the subrecipient and the HRSA. So HRSA will review the subrecipient agreement of the prime grantee, but rarely will get in or audit the subrecipient. All of that compliance stuff falls on the prime grantee. So it's quite a lift of a prime grantee to take that on, but it happens, absolutely. And so it's about the relationship between those parties and, of course, transparency. So we can move to the next one. I'm going to spend a couple slides talking about subrecipient, and then we'll move on to lookalike. So one key thing is the autonomy of the subrecipient. They need to retain their separate corporate identity and be licensed. They're responsible for their Medicare, Medicaid provider numbers. They're responsible for being fully compliant with Section 330, the implementing regulations, HRSA policies, the 19 program requirements, if you will. And in order to become a subrecipient, the prime grantee has to do a change in scope. I'll talk about that in the next slide, but I'm going to stay here for now. And it's not a competitive process, so that's obviously a big perk. So if you keep going down, let's see, provider services in accordance with subrecipients' policies, which have to be reasonably consistent with the prime grantee's relevant policies. So you don't get subsumed up into the prime grantee, but of course they have to be harmonious. And the subrecipient bills all applicable third-party payers in its own name and retains the revenue. By being a subrecipient, you get a portion of that grant, right? 10%, 30%, I mean, it's negotiable. It depends on the scope of the project that you're able to fulfill. And then because you've got the grant, you do get the federal tort claims coverage, or you're eligible to be deemed for FTCA coverage for that subrecipient site, because it could be your entire entity, or say you're a multi-site clinic. It might just be one of your sites in case the site that is a subrecipient gets the FTCA coverage. Would also be eligible for an anti-kickback safe harbor that's specific to 330 grantees. Would also, of course, be eligible for the prospective payment system, the PPS rate under Medicaid, and 340B and all the other things that come with being a grantee. So we'll go ahead and go to the next page. Sorry. So the oversight by the prime grantee. The prime grantee is fully liable to feds for the funds awarded to the subrecipient. So again, you definitely have to be friends. The prime grantee also has to be assured of the subrecipient's compliance with HRSA requirements. So that can be done through audits, records, review, etc. And it says here, for instance, that prime grantee must maintain an appropriate level of oversight and monitoring over subrecipient to ensure that the sub is compliant with Section 330 requirements. So they can do site visits, they can do audits, quality assurance reports, but they want to go in and they want to see the financial audits, and they want to look through the policies and procedures and make sure that the sub is doing a sliding fee scale right and that the board is in compliance, et cetera. Prime grantee has authority to take corrective action. These should be provisions that are in that subrecipient agreement. So corrective action if instances of subrecipient's noncompliance, material weakness, or mismanagement are detected. Now I'm going to stay on this for a moment just to also highlight that if you become a subrecipient, you are taking yourself out of the running for a future NAP. At least historically, when NAPs come up, in order to be eligible for that grant, you need to not be receiving funds under any Section 330, and that it would include the subrecipient status. So that's a big reason that people don't do it. If you want to set yourself up to be an independent prime grantee, becoming a subrecipient is going to take you out of the running. And to talk about the agreement a little bit, also the super circular rules, which I imagine are on many people's radar, would apply to these situations. So that's something that is deserving of its own webinar, most likely. But there's a lot of different requirements that will get passed down from the prime grantee through the subrecipient agreement to your entity as a subrecipient. So let's go on to the next slide. Lookalike model. So this is the third pathway. And lookalikes are pretty common as well. And part of that is because it's a non-competitive process. It's a rolling application. One of the heavy lifts here is that you have to be operational and fully compliant 6 months prior to when you apply. So that means, for instance, as a Ryan White clinic, your board is likely to have to change in order to become patient-led, maybe not, but presumably, and start taking on the authorities that Section 330 requires in terms of the level of scrutiny of the different policies and procedures. Also, we can talk about this. I have a question in here a little bit later for you, but changing the way that you charge patients under many circumstances, and of course the expansion of services to include pediatrics, OBGYN, et cetera, everything that is on that Form 5A that I mentioned earlier. So 6 months before you even apply. And it is operated between HRSA and CMS. So they work together where HRSA is responsible for assuring compliance with the requirements under Section 330 and making a recommendation to CMS for the designation as a lookalike, where CMS actually is the one with the final authority to designate applicants as a FQHC lookalike. This is a common backup plan for organizations, and it's thought to poise organizations to apply for a grant really well, which I think is true because HRSA starts to form a relationship with you as a lookalike so that later when there is a competitive process and you put in your application, you can elevate it in that way. And you're also, as I mentioned earlier, NAPs, you have to be compliant 120 days from the point of grant award. Obviously, if you're applying as a lookalike, you're already compliant. So there's these different things that strengthen your application by going this route. And the other thing is that you do get that PPS, that higher Medicaid rate while you're a lookalike. So that's a big allure, and as was noted in your poll results. So next slide, please. So this is a bit of a roadmap to that non-competitive rolling process. You submit your application to HRSA, who reviews it for completeness. In this case, oftentimes they will go back to people and let them know if it's not complete, which is very nice. And then they will move it forward, send recommendations to CMS. CMS sends it to the region, and then the recommendations, apologize for the duplicate slide there, CMS decides and designates the organization as lookalike or not, and then sends it back to HRSA to notify the entity. So if an application is complete and compliant with all the program requirements, it goes through quite a bit faster. And on average, HRSA's initial review of the application takes about 180 days. So that can be useful to know. Next slide, please. So I hope you find this chart useful. I think that it's very helpful personally. It highlights the FQHC benefits, 340B, drug discount program, the grant itself, the FTCA malpractice coverage, with regards to the different pathways chosen. And so the grantee model, the most common one, gets them all. They are an FQHC, they get the FQHC benefits. Subrecipient model for the portion of the entity that is a subrecipient, which could be all of it or could be a site of several, they also are eligible for the full range of FQHC-associated benefits, where a lookalike does not get the first three. So they don't get a grant, that goes without saying kind of, but because they don't have the grant and they're not the recipient of federal funds, then the incentive for the federal government to then extend the Federal Tort Claims Act, malpractice coverage, and the anti-kickback safe harbor to safeguard federal funds doesn't apply. So you can kind of work the logic there that if you didn't get the grant, you're not going to get these other two protections in the first few boxes. But you do get the higher Medicaid rate, the prospective payment system, drug discount eligibility, and other benefits such as getting providers from the National Health Service Corps. So we can go ahead and move forward from there. So the multi-site strategy, I didn't want to pick on any particular state, so I decided to go with this. But if you, for instance, in a hypothetical, I've seen a Ryan White grantee that has a main clinic that is robust, impressive, would be easy to transition into a FQHC with regard to the scope of services, and it's perhaps in the inner city. In the meantime, they have a couple of rural sites that just have case management, so it'd be a huge lift to expand those services. But the main site has FQHCs around every corner, so there's a service area overlap concern and a question of whether or not those neighboring FQHCs would submit letters of support or would actually oppose the Ryan White grantee's main site from becoming an FQHC. So the competitive process is challenging, to say the least, for that entity who's perhaps in Gondor. But doing the smaller site that's somewhere out here in the Shire would not have a service area overlap and would actually even have the support of a neighboring FQHC that needs help in this rural area, for instance. And the neighboring FQHC out there says to the Ryan White grantee, we're willing to make your satellite site one of our subrecipients. So then the grantee has to consider, well, then the Shire location wouldn't be eligible for a later new access point grant, and yet we would get higher Medicaid payment and we would start to get our foot in the door and understand all the requirements more. But then there's governance implications if you do a multi-site strategy where some of your locations have FQHC status and some don't. It's certainly easier if they all do, and if you got a big grant and everything was great, but people are having to be quite strategic when they think about, what makes sense for the community, the resources that are here, the needs that are here, and what we're able to do. So the underlying point on this slide is really that it's a case-by-case situation. So next slide, please. So in an attempt to be encouraging and really tee people up for a successful entry into one of these pathways towards FQHC status, I want to talk about a few ideas for that first step down the road. Next slide, please. A needs assessment, again, something that you all are likely familiar with. Conducting a needs assessment specific to FQHC status is not only highly recommended, but will be required. As an FQHC, you need to have one. So associated to an actual document that is a needs assessment, you look at the service area that you're proposing to deliver care to. Are you in a medically underserved area? Are there medically underserved populations where you live? Here I entered a URL that you can go to, enter in an address, zip code, and it'll tell you if HRSA designates that area as an MUA or an MUP. And then check the UDS mapper. That's a HRSA project, HRSA funded project, and that is Uniform Data Systems, and that'll show you also, help you dig down and look at your service area in terms of the need there, and then how to frame that in the application. PIN 2007-09, all of these are easy to access online if you search for HRSA PIN 2007-09. it's likely to come right up as a PDF document, but that speaks specifically to service area and how HRSA analyzes service area overlap. And that lends itself to community partners. Who are your community partners? Can you get letters of support for your application, specifically from existing FQHCs, but from community partners in general? Another important aspect to becoming an FQHC is a communication strategy. And we're not just talking about the communication to the other FQHCs, community partners, but really to your patients and to your staff. There is often tension, obviously, in changing your identity a bit or expanding services from being something that is more niche to more general. Are you going to lose your branding or your sense of self? And thinking about and being very mindful of how you preserve the history that you bring with you and how you make sure that you maintain a safe space and you're truly open to all. That communication is key. So resources can include all sorts of associations. National Association of Community Health Centers has a lot of good resources. The Target Center, I think you're all familiar with, has great resources. PCAs are the primary care associations. Those are the state-based health center trade associations. Your PO, as a Ryan White grantee, you likely have a HRSA assigned project officer, and they can be a great resource. And planning grants are something to explore. There are times where HRSA has offered planning grants, say in the realm of about $80,000, give or take, where that allows you the luxury to really dig in, hire a consultant, and get that needs assessment done, et cetera, and explore whether this is right for you. But it's not necessarily just a HRSA planning grant. It could be other sources of funding that would be specific to deciding whether or not, or how to, and whether or not to pursue the FQHC, if that's a right fit for your organization. Also, I wanted to note that within NAC, there are many organizations that are both Ryan White grantees and FQHCs. For instance, like the Fenway up in Boston, they have a Fenway Institute that provides a lot of information around HIV/AIDS, LGBT services within FQHCs for FQHC boards. They try to do education that way of teaching FQHCs how to be better HIV/AIDS providers. And then also there's a task force within NAC of those Ryan White FQHC entities that can be great to rely on. Also, one moment. I think next slide, actually. So this is my second and final poll today. Similarly, if you choose the final option, please go ahead and type that in the chat box or the question box. So here it's, what's the greatest perceived obstacle for your organization to becoming an FQHC? Is it the community-based board, the hideous uniforms? These are all, well, you can say whatever you like, decide what you want. The fee schedule for patients, or the expansive scope of services, or other, in terms of feeling like it might be a stumbling block. So go ahead and take a minute, and then we will review your answers. Perfect. And Andrea, were there any others? It doesn't look like it from where I'm sitting.
I'm not showing any either.
So sounds good. And how did the numbers come in, if I may ask? It's not showing up on my desktop.
Let's see, we will launch that now. There you go.
Great. So you got 24% saying the community-based board is a obstacle, 4% talk about the fee, and 60% expansive scope of services, where there are 12% who said other. So I would love to hear your answer for what the other is. That'd be great, because then I could try to speak to it. Fortunately, the uniform question or answer in both polls is a joke, because I talk about there's so many systems and everything like that, but of course there's no uniform at all. But I thought I'd give people a goofy answer. But again, there's no right answer here. It's case by case, and the three identified ones, A, C, and D, seem to be the most common obstacles to becoming an FQHC. So on that note, we'll go ahead and go to the next slide. That's called community-based board.
An hour from here, I think, really.
If someone's not muted, just so you know.
11:15 would work well for me, I believe.
Hello.
Hi, please mute your line.
I sure do.
I'm just going to have to talk louder and over this person. So the community-based board. The community-based board, as you saw, was the second highest selected answer.
Okay.
And I imagine that.
Okay.
I don't know, Andrew, if you can do anything about muting the line, or otherwise I'll just.
We're working on that because
try to plow through.
So we'll
yeah. Okay. And I'm sure that one was just a minute ago. So community-based boards can be very intimidating. Like, where do we start? How do we bring people on? Again, this is a refresher from the last webinar, but again, just important to clarify that health centers are required to have at least 51% of board members be consumers. And you can cultivate new board members through staff recommendations, patient advisory board members. That's very useful.
Is there a number, just in case I got in a snap?
And
yeah.
In terms of understanding that the board member must be a consumer of the health services, otherwise known as a patient, it's important to wrap your head around what is a patient defined as. So a patient is defined as a current registered patient. This comes from the HIVMA policy, not the statute. A patient is defined as a current registered patient of the health center who has accessed the health center in the past 2 years to receive at least one or more in-scope services that generated a health center visit. So it's a pretty relaxed definition. It's specific enough to say, no, you need to go see a provider there. You can't just be getting your meds there or something like that. But in the last 2 years, as opposed to every year. And there's often a question of whether or not dental counts, and then that becomes a question of, well, is it in your scope of services? That's a HRSA-approved scope of services. The answer is probably yes. So, again, tactics for recruiting great new board members who are patients of the health center include an advisory board that might be a feeder to the board of directors, and then, again, talking with staff about possible recruits. And then also you can have them sit on your various committees, or just in general, prospective board members sit on committees to see if it is a good match. The PIN 2014-01 is referenced here because it's a very recent HRSA policy that came out and defined patient, and also goes into depth about the governance requirements and the patient-based board requirement. So we'll go ahead and go to the next slide, but hopefully that gives you good ideas about how to start down that road of bringing on patients onto your board. So the charges and discounts can be very different from a Ryan White program. So one quick thing is that, so FQHCs, they have to have a schedule of charges designed to cover the reasonable costs. So the federal government doesn't want to give the sizable grant only to have it go to subsidizing all patients that walk through the door. That said, on the other hand, the FQHCs must give discounts to patients who are under 200% of poverty on a different scale. And those patients who are under 100%, they have to charge either nothing or a nominal fee. And nominal is going to be regional and based on a case-by-case as well. But, you see $10 is kind of common as an example. But, of course, that other funds, including a Ryan White grant, can be used to discount services for patients above 200%. The 330 cannot. So a lot of times Ryan White will require the discounts for eligible patients for HIV/AIDS services. So they don't need to be inconsistent. A lot of, like I said, around the different members of NAC who are Ryan White grantees and FQHCs, this is not uncharted territory, and there's a lot of models to look at and resources that are out there about how to square the different requirements, specifically around charging patients and operations, collections, et cetera. So we'll go ahead and go to the next slide. We see that we're almost at the Q&A time, which is perfect because this is my last substantive slide. This is the scope of services. This is the area that seemed to give most people like the biggest pain point for participants today. They got the most number of yeses in that last poll about this being a hurdle. So the scope of services, good news is that is the last bullet here, which is that services can be provided directly or by established written arrangement, by contract or referral. So while the services in that first portion talk about the full range, right? So they have to provide or arrange for the provision of all required services, including basic primary care services, diagnostic lab and x-ray, prenatal, postnatal, et cetera, et cetera, et cetera. Enabling services, which include outreach, transportation, translation, education as well, and case management. So that can be a heavy lift for any entity, obviously. And of course, this is a time of a lot of change in the healthcare industry, and there's a lot of excitement around growing your own services, but you can also collaborate and lean on others through a very structured, methodical way of these written arrangements that Carrie Bill, a partner with the law firm, will be speaking about on June 10th. So I'm going to go ahead and leave it at that, and the next slide highlights that date and time for you all, and we can go ahead and move to the Q&A portion.
Great. Well, thank you so much, Catherine. That was terrific. So just going back, and this question came in earlier, I think when we were going through the FQHC application process, and the question is, does the annual grant, is that supposed to cover the annual budget for the FQHC? So I assume that's referring to the Section 330 funding? So how that plays a role?
Right. I'm going to go ahead and... So the question is, can you hear me?
Yes.
Speaker. The question is whether the Section 330 grant is supposed to cover all of operations. Is that correct?
Yes. The annual budget is the way it's phrased, but I assume that so kind of what role that funding plays in the overall operating budget of the community.
No, that's a great question. The easy answer is no. Whether it does for some, I mean, that would be fantastic. But really, what it does rather is that it sets the organization on this path to then be able to earn program income, which is, like funds received by virtue of being a federal grantee, and by being an FQHC and the PPS rates paid under the Medicaid and Medicare programs, you are typically able to cover your costs more. I mean, the PPS is specifically that you would be covering the cost for the services you provide. Instead of Medicaid being the worst payer, it is no longer the worst payer. So you are able to stretch those dollars and sustain yourself and hopefully grow more programs. It also makes you eligible for 340B drug discount programs, which if you weren't before, can also save a lot of dollars, obviously be a benefit to the uninsured patients, and help you expand your services to the medically needy. And then so essentially, there's health centers that run the full range in terms of what portion of their total budget is the grant. For some of them, it may be the majority, but for most of them, it is not the majority of their budget. Rather, it opens the doors for these other program income lines.
Great. And first, I'll start with just a reminder to please submit your questions via the question box should be on the right-hand side of your screen. And if we don't get to them today, we can kick off the next webinar with the questions. But this next one, I think, is probably on the minds of a lot of the participants. And it's basically, will you provide some tips on how to approach an FQHC, becoming an FQHC for a Ryan White provider. So special tips for Ryan White providers who are considering this, and in particular to try to eliminate some of the myths. So hopefully I captured that correctly.
Trying to eliminate some of the what?
Some of the myths for Ryan White providers who are considering becoming an FQHC.
Okay, so I'm gonna
just
dive in and see if I get the question.
Okay.
Spirit of the question right. But so first, what I heard was tips for how a Ryan White grantee would approach an FQHC. And I imagine that's either becoming a subrecipient to them or approaching them to say, hey, we want to be an FQHC grantee ourselves, independent of you, and we would love your support because you're our neighbor and we get to work collaboratively together. That's probably, does that sound about right to you?
That sounds right.
Yeah, so I think in terms of, so there's different ones. Well, and another one, of course, is read the most broadly is how does a Ryan White grantee approach an FQHC generally. So in that case, I would start off with actually approaching perhaps a Ryan White grantee who has become an FQHC that's not in your area and kind of talk to them about some of their learned experiences. Again, a collaboration of those organizations there's a LGBT task force within NAC that obviously, that has that history to it. But then in terms of approaching regional FQHCs, service area overlap can definitely be a sore spot for folks, but the reality is that in this country, the need is overwhelming. And so I think that in terms of approaching it, it's not it's approaching it, of course, not as a, hey, I'd like a portion of your grant, or like, hey, I'd like a portion, like the way that you would approach any collaborative partner, which is to say, these are the great things that we do. We see you do these things really well. Where are the opportunities for mutual growth? Let's brainstorm on all of this and have a few sit downs. And, obviously you want trusted partners. There's different dynamics. If you are going to become a subrecipient to an FQHC, that's obviously a lot more intimate. It requires a little bit more work together than getting the support of neighboring FQHCs, because sometimes there's also been successful FQHC applications where a neighboring FQHC didn't submit a letter of support, but it also didn't object, if you will. So you're strongest if you can get a letter of support, but if you can neutralize them and have them appreciate that you're not a threat, that you have this community that you're serving, that there are these other pockets of people who would benefit from you entering the doing, more work, and then also entering into referral arrangements with them. So aside from, I kind of talked about the two extremes. One is, go ahead and become a subrecipient, which is extremely involved, or just, get a letter of support or neutralize them on the other side. But there's that in between where you get some kind of an affiliation with an existing FQHC as you tee up to become an FQHC in transparency. And that happens all the time. So someone who's saying, yes, we want to become an FQHC, and when we do, we hope to be able to use you for pediatrics. And we would love to refer all our patients' children to you. And that's, again, something that will be discussed in our next webinar. And then also, you can talk about the number of patients, and talking about your patient base and just helping them understand the work that you do and the lives that you touch already. So I hope that helps some. But certainly entering it, also in terms of dialogue, obviously just start with open-ended questions to understand more about what their strategic vision is.
Great. And that actually kind of blends well into the next question, which goes back to the lookalike, slide 18. Let me try to scroll back. And where they're asking about if you have to meet all of the required services for 6 months before applying for a lookalike status, or is there some flexibility with getting the services contracts in order after the application date? And the example given is for pediatric services, for example.
Oh, that does blend nicely.
Yeah.
So flexibility is not the strong suit in compliance, but I would say that, so you do have to be operational 6 months before you apply. But does that mean that you have to have, I mean, you don't necessarily, obviously, you're an ever-changing, growing organization, and you're just going to get, better and better and better. But in terms of the first webinar 2 weeks ago, we talked about this HRSA 19 program requirements, and there's a site visit guide. That's the HRSA program site visit guide. And you look through that and ask all these questions about compliance and, who's on your board, how often do they meet, do they exercise these authorities, scope of services, do you meet everything that's in the 5A, either directly or through referral. So, for instance, what if you are working to be in compliance from January to June, and then come June you find out there's some hiccup that happened there that, a referral partner fell through. Then just like any business choice, you have to decide to be working on that, and perhaps you submit the application and continue to be working on improving those conditions, if you will. So I think there's kind of a business choice about the timing, the risk, all the moving balls, of, if that makes sense. So essentially, I think that HRSA, if they saw an application where there wasn't even a memorandum, there was no provision of pediatrics, and there was no MOU with a nearby provider or evidence of communications with a nearby provider to try to bring that into scope or into your set of services, they wouldn't look fondly upon that. But if they could see that there was this effort going on and that it was pending and that it was, that would probably change their outlook in terms of their confidence in your ability to meet those requirements and become a patient-centered medical home with integrated care.
Okay, great. I'm going to try to move quickly along so we get to as many as possible. So the next one is, are there startup grants, which I think you kind of alluded to, but available to Ryan White Part B agencies, and those typically are the state departments of the HIV, state health departments, their HIV section, to become fully integrated care clinics?
I think that is a terrific question. As far as specifically, I can't speak to that, I have to admit. I am certainly aware of HRSA regularly doing planning grants, and they are open to all eligible organizations, so not current FQHC grantees. And then there'd be one award per organization with a maximum of $80,000, one-year project period. And then those funds are to be used for kind of explorative, and let me know if I got that wrong, but I thought that the beginning of the question kind of spoke to that, looking at the transition, whether it's not specific to Part B, and there might be further grants specific to that, and that's where your project officer may be a great source, because they tend to be very tuned into, looking at strategically how to be financially savvy with, Ryan White funds, often, coming into question and saying what other avenues are there for the organization's future in terms of thinking about, being eligible for PPS through FQHC status. And so I think they might be a great resource.
That's a great recommendation. The next question is, and I had this question too a little bit, is what is the difference between a subrecipient agreement and services provided via established written agreement, contract, or referral?
That's a fun question. So just to highlight why I'm in the field I'm in. Let's see. So a contracted referral, for instance, a lot of times we'll draft those with, that might be through a health center with a hospital. That happens a lot. And there are, I'm going to go with, there's two different types of referral arrangements that can happen. One is where the health center pays for the service, and then there's another one where they don't pay for the service, right? And then the provider of that service, starting to get redundant, bills for it, but has to actually comply with the sliding fee scale and other elements, and they are not liable for each other. rather in the contract there'll be indemnification clauses, and they're responsible for themselves and their conduct. They are money. I guess the money can change hands just in terms of the value of the service rendered, the actual medical service, the clinical service. It's the topic of the referral. In contrast, the subrecipient award agreement tends to be more all-encompassing. Big chunk of money from the prime grantee's bank will come down and flow to the subrecipient, and in turn, that prime grantee is going to rely on the subrecipient for a scope of services. So in that way, it's similar, but they're also going to be responsible for the full compliance of that entity. So it's a bigger task, essentially. I hope that helps. So the subrecipient model is, a bigger project, not as common, and the referral arrangements about a particular service, behavioral health, X-rays, whatever it is a lot more common and a lot more, I think, you see more players in that field too, in terms of hospitals get involved and things like that.
Okay, great. And if we didn't completely answer your questions, please send a follow-up note, and we will try to cover it during the next webinar. So now we're a minute after. We have one more question. I'll leave it to you if you want to take that, or
Sure.
Okay, it's the final question for today is: when a written contract is established for services, is it still the responsibility of the lookalike to collect the data for the annual report? And is it also required for the contracted provider to accept the lookalike's designated sliding fee scale?
That is a great question, and actually it's probably conducive to being discussed further in on the 10th.
Okay.
But I think I actually can't see it in on this, because I have the chat feature as well, but I can't see that question somehow.
We can
so
send
it's a
that
little bit of a confusing question. But I think that what they're getting at is this idea of, and I don't think it matters whether it's a lookalike grantee subrecipient. So I think that's part of the confusion for me. So if an entity that's an FQHC does a referral arrangement within their required scope of services, the entity that they're referring to for that does have to apply the sliding fee scale. That's one part that might illuminate. So I think that with that, I might wrap it up there. But certainly, as an FQHC, if you looking at that Form 5A that has about 25 services, give or take, if you can't provide them directly, you can provide them through referral if you have these agreements with the bells and whistles that are required by HRSA in those agreements, and everything on that form, whether direct or through referral, needs to comply with the Section 330 stuff, which includes offering things to eligible patients at a discounted rate.
Great. And to be continued possibly on the next June 10th webinar as well.
Continued, and with great appreciation for everybody's time.
Great. Well, thank you so much, Catherine and Emily. Thanks to everyone for participating today. The final slide is Catherine has offered her email here if you do have other questions. You also can submit them to us at HIVMA, and we're happy to follow up. But we hope you'll register for the final webinar on June 10th, and we will be following up with some additional reading resources. So thank you very much, everyone, to the presenters and participants. Bye-bye, everyone.